Hello, this is Kamran Bhopal and I'm back again with another skill station for the ST3 urology interviews, and this is a flexible cystoscopy station. So the question is, you're in a one-stop hematuria clinic. A 67-year-old gentleman has come with visible hematuria and has a history of smoking. How will you assess the patient? So, if they ask you this, then it's the history and clinical exam, which we've already done previously in the outpatient visible hematuria station. Investigations: blood including PSA with counseling, urine dip and MSU for microscopy and culture, flexible cystoscopy, ultrasound KUB for non-visible, and CTU with excretory phase for visible hematuria. So these are the investigations you organize. Then indications for flexible cystoscopy can be for diagnostic and therapeutic reasons. So diagnostic reasons are hematuria, recurrent urinary tract infections, irritative LUTs such as bladder stones/cancer, bladder outlet obstruction such as stricture diagnosis, monitoring for bladder cancer after resection, so surveillance reasons. Therapeutic reasons include Botox injections, stent removal, or catheterization with difficult catheterization. How will you consent? I'll leave that to you. You can have a look over the consent. They may not ask you about it because the only real risk factor in a flexible cystoscopy is developing urinary tract infection, or inability or misdiagnosis, inability to go in, or failure of access, or missed pathology. There's not too much to say there, and a little bit of bleeding afterwards. So 3 or 4 risk factors. They may ask you this, but it's good to be able to know this thing, because flexible cystoscopy is the first thing that you'll do as a registrar, and because you'll have your own clinics doing flexible cystoscopy, and you should be able to do it, and henceforth you need to know the risks involved with it. Talk us through the procedure. So you just need to tell them how you would do a flexible cystoscopy. I will take an appropriately prepared and consented patient to the flexible cystoscopy room, ensuring that urine dip is negative, bladder is emptied, and patient has no allergies. The men should be in a supine position, whereas females will be in a frog leg position. Clean the urethral meatus, drape, check the equipment, fluid attached, screen working, and white balance done. Instill a gel in the urethra, insert the scope, ask the nurse for the irrigation to be turned on. Look at the urethra, prostate, ureteric orifices, systematically look at the posterior wall, the dome, the anterior wall, and both lateral walls, and also do a J maneuver. Okay, so this is then what are the other types of cystoscopy that you know about? We know about blue light cystoscopy, which use 5-ALA or 5-aminolevulinic acid, which is instilled in the bladder 1 hour in advance, and the tumor cells convert the 5-ALA or hexaminolevulinic acid into protoporphyrin, and blue light is used, and the areas which are abnormal show up red. So there's a couple of researchers you may want, I'll just mention it, you really don't need to know them for the interview, but if they ask them, it's brownie points. So Keish et al. Says 20% increased in diagnosis in non-muscle invasive bladder cancer, and Kosh suggests 39% more sensitivity in carcinoma in situ as compared to white light. So what is narrowband imaging? So narrow bandwidth of light is used in narrowband imaging. It is absorbed by the surface tissue, causes increased capillary visibility, hence increased contrast between the normal mucosa and suspicious vascular lesions. Right, so question says, you see a 2 centimeter papillary lesion, how will you proceed? I will finish the procedure, ask the patient to dress up, use the toilet if needed, and take the patient into a private room with a specialist nurse ideally present. I will gently break the bad news, preferably in the presence of family or relative, and start the consent process for a TURBT and book the case in 1 to 2 weeks on the cancer pathway. I will give the patient BOWS leaflets and the urology specialist nurse's number and document the procedure, writing about the size, site, and the type of tumor, and also request a CT urogram if not already requesting, and also the EGFR. So the histology shows after TURBT a G3PT1 cancer. What are your next steps? The patient needs to be discussed in the multidisciplinary team meeting and will need re-resection in 6 weeks as per NICE guidelines. So remember my outpatient scenario for bladder cancer or visible hematuria, in which I had risk stratified bladder cancer into low risk, intermediate, and high risk bladder cancer, and G3 and PT1 both are higher risk bladder cancer, which need re-resection in 6 weeks time. That's the end of our scenario, and we'll be back with another skill station, which will be ureteric stent insertion. I wish you all the best, and I'll see you next time.